अस्सलाम वालेकुम। आज हमारा टॉपिक है hemolytic anemia and we are going to discuss some basic details of it. Our learning objectives of this lecture will be first of all हम डिफाइन करेंगे कि hemolytic anemia कहते किसे हैं. Secondly, we will differentiate between the intravascular and extravascular hemolysis. Alright, we will first of all tell what it is basically, and then we will differentiate between intravascular extravascular hemolysis. Then we will see the acute and chronic hemolysis. And after that we will look at the classifications of hemolytic anemia. Alright, and then comes the clinical features and the body findings. So here comes the definition. According to our book Hofbrand Essential Hematology, it is defined as the anemia that results from an increase in the rate of the red blood cell destruction. Okay, हम ये सब जानते हैं कि रेड ब्लड सेल की डिस्ट्रक्शन होती है आफ्टर द 120 days लाइफ स्पेन ऑफ नॉर्मल लाइफ स्पेन ऑफ रेड ब्लड सेल्स. ऑलराइट, अगर अब उनकी नॉर्मली तो एक रेड ब्लड सेल की डिस्ट्रक्शन हो रही है, लेकिन जब ये डिस्ट्रक्शन एक्सेसिव होने लग जाती है, बहुत ज़्यादा अमाउंट में होती है, देन वी विल डिफाइन इट एज द hemolytic anemia. hemolytic वर्ड, ये जो hemolytic anemia का वर्ड है, अगर हम इसी की तरफ देखते हैं तो hemolytic का मतलब है कि hemolysis का मतलब है कि रेड ब्लड सेल की, हीमो मीन्स रेड ब्लड सेल एंड लाइसिस मीन्स ब्रेक डाउन. सो इस वर्ड से हमें पता चलता है कि ये रेड ब्लड सेल की डिस्ट्रक्शन की बात हो रही है यहाँ पे. So, looking at this word, hemolytic anemia, we can find that increase in the rate of red blood cell destruction. Then hemolysis की हम बात करेंगे. What is basically the hemolysis? Hemolysis is the breakdown of red blood cell, and how it take place. It may take place in the intravascularly and extravascularly. Right, in the intravascular, intra means inside and vascular means vessels. So inside the vessels, this type of the hemolysis is inside the vessel, where extravascular hemolysis, extra means outside, vascular means vessels, so this type of the hemolysis is outside the vessels. Means intravascular hemolysis is the hemolysis taking place inside the vessels, and the extravascular hemolysis means the hemolysis is taking place outside the vessels. Alright, the blood vessels we are talking about. Okay, the intravascular hemolysis is the hemolysis of the red blood cell directly in the circulation, and extravascular hemolysis is defined as excessive removal of red blood cells by the macrophages of the reticuloendothelial system. Okay, normally our red blood cells are removed by reticuloendothelial system. Okay, we know about that. But when there is excessive removal of red blood cells by the macrophages of reticuloendothelial system, we term it as extravascular hemolysis. Here comes the difference. Intravascular hemolysis, when we do the peripheral film, okay, of any blood that is intravascularly hemolyzed, we will see the schistocytes in the peripheral film. Okay, and in the extravascular hemolysis we will see the spherocytes. Alright, in the intravascular hemolysis the heptoglobin levels will decrease, or it may become absent even. Now I will tell you what is basically the heptoglobin. Heptoglobin is a plasma protein. It is present in the normal amounts in our blood. Alright, it is a plasma protein. So it has the ability to bind to the hemoglobin. Alright, when there is hemolysis, there is excessive breakdown of red blood cell, so there will be excessive release of hemoglobin into the circulation. This plasma protein heptoglobin will bind the excessive amount of hemoglobin with it to bring the hemoglobin level to the normal. So when it will bind the free hemoglobin with it, its level will be decreased in the blood. That's why intravascular hemolysis have the heptoglobin levels decreased or even absent. Whereas the extravascular hemolysis, the heptoglobin will mildly decrease. Okay. Then in the intravascular hemolysis, we have the urine hemosiderin. Alright, means that there is excessive red blood cell breakdown. The hemosiderin will definitely come in the urine. Whereas the extravascular hemolysis, we don't find any hemosiderin in the urine. Alright, here same with the case with the hemoglobin. the hemoglobin will be present in the urine in the intravascular cases, not in the extravascular cases. However, a test done in the laboratory known as the direct DAT test, it is usually negative in the intravascular hemolysis, whereas it is highly positive in extravascular cases. Alright, LDH level will be increased in both the cases. As there is red blood cell destruction, the LDH level will increase definitely. Here comes the acute and chronic hemolysis. From the word acute, we know about it as some hemolysis that has a quick onset. Okay, and in the chronic, we know about it is slowly progressed hemolysis, means from it is from many years. All right, from a very long time. But I have presented the difference between the acute and chronic hemolysis, so that you may know about the laboratory findings of both of them to easily diagnose them. Okay, here comes first the clinical feature of that, means that the fever will be present in the acute hemolysis cases, whereas the fever will not be present in the chronic hemolysis cases. Alright, or maybe it is a very low fever in the chronic cases. Alright, then come the splenomegaly. Splenomegaly means there it is the enlargement of spleen. So, in the acute cases, right, means that the quick onset, the hemolysis, which has a quick onset, the spleen don't have much time to become enlarged. Alright, as it is a acute case, so the splenomegaly will not be present in it. Whereas in the chronic cases, we have a prolonged hemolysis continuing for many years. So the spleen is enlarged in it because most of the destruction of red blood cells taking place in the spleen. The red blood cell spleen move from in the circulation from the spleen, they get ruptured. All right, because of the disorder in their structure, they become leptocyte most of the cases. So we will see the splenomegaly in the chronic cases and not in the acute cases. Okay, then come the jaundice. Jaundice means the yellow discoloration of sclera. Alright, you all know about that. When there is red blood cell destruction, when there is hemolysis, there is jaundice. Same with the case with the HDN, hemolytic newborn disease, we see the jaundice. So in the acute hemolysis cases, the jaundice is slight, alright, slightly present. Whereas in the chronic cases, it is frequently present because the body has enough time to show the symptoms of jaundice, alright, that it is a chronic case, a prolonged case. Then come the hemoglobin urea. The hemoglobin urea will be frequent in the acute cases, whereas it will be absent in the chronic cases, because in the chronic hemolysis the body has enough time for the compensatory mechanisms activation. Alright, because of the activation of these compensatory mechanisms, there will be no hemoglobin in the urine in the chronic cases, whereas in the acute cases, the body don't have much time. Alright, so the hemoglobin will be present in the urine. Same like the case with the hemosiderin. Alright, the hemosiderin urea will be present in the acute cases, where it will be absent in the chronic cases. The renal failure will be present in acute cases. The reason will be same, and it will be absent in the chronic cases. Alright, because of the activation of compensatory mechanism. The gallstones will not be present in the acute cases because for the formation of the gallstones, it take much time, and this time will be given to the body during the chronic cases. Alright, in the chronic cases, the body have enough time, and the body suffer from a very long time. The pigmentation, the pigments of bilirubin, alright, in the gallbladder start to accumulate, and then they later on give the form of the gallstone. Okay, move on to the next. We have the classification here. There are two major types, the hereditary and acquired. The hereditary means simply the intrinsic red blood cell defect, means there is any kind of the mutation in the chromosomes, in our genes. Alright, Because of their mutations, we have any intrinsic red blood cell defect. It may be of any kind of a defect in red blood cell structure, like the cases with the hereditary spherocytosis, all right, in which there is a defect of red blood cell structure, and because of that defect, the red blood cells, when passed through the spleen, they get ruptured, and the hemolysis of red blood cell begins. So we have the heredity type, and then we have the acquired type. Acquired means there is any extracorpuscular or environmental change that result in the hemolysis of red blood cell. Okay, then we get the other result, get the acquired hemolytic anemia. Then the clinical features. Clinical feature, first of all, we have the jaundice here. Jaundice means, I have told you before, the yellow discoloration of sclera, of eyes, and it has many other things as well. Also seen in the ATN, like hemolytic newborn disease. Alright, splenomegaly. Splenomegaly also do something that is because of the red cell destruction. It means that it is an enlargement of spleen. Alright, because spleen have to do more work. That's why it has become enlarged. Then comes the pillar or the mucous membrane. Pillar or the mucous membrane is something that is present in all the anemias. It is not particularly it. It is present in all of the anemias. Then there is HB, a decrease in the HB hemoglobin. There is the pillarness of the mucous membrane there. Okay, then these points are something which are particular to the hemolytic anemia. Like in the urine, normally we have the bilirubin. All right, we don't have the urobilinogen there. All right, when in this case the hemolytic anemia is there, we have no bilirubin in the urine, whereas there will be the presence of urobilinogen in the urine, which is abnormally present. All right, so what do this do? Urobilinogen do? It is basically a colorless compound, all right, and it turned the urine dark on standing. As I told you before, that it is a colorless compound, but when it is exposed to the light, it convert into bilinogen, which is a dark color and highly colored compound, which give the urine its dark appearance after some time. So this is urobilinogen is responsible for the dark coloration of the urine, which is usually seen in hemolytic anemia cases. Then come the pigment gallstones. I told you before, there is accumulation of bilirubin in the gallbladder and many other things, which later on result in the gallbladder stones. Here are some disease-specific complications. I've listed there four of them. First of all, there is ulcer around the ankle. Alright, and this is something which is seen in the patients of sickle cell anemia and hereditary spherocytosis. This is something I have told you before. Hereditary spherocytosis means there is it is in it there is abnormality of red blood cell structure, and because of that, we will have the spherocytes in the blood, and these spherocytes, when passed to the spleen, they become rupture, so the hemolysis of the red blood cell began. Then we have the bone deformities, and it is something which is seen in thalassemia major patients because they receive regular blood transfusions. As a result, they will have the bone deformities. Okay, and then come the discoloration in peripheral regions, and this is something most commonly seen in cold reactive autoantibodies patients. All right. Then come the thrombosis, and it is seen in the proximal nocturnal hemoglobinuria. Okay, next we have the findings. In the laboratory findings, I have listed the serum bilirubin. It will be raised in hemolytic anemia cases, as as there will be no release of the bilirubin in the urine, and it starts to accumulate in our serum. All right, and also in our gallbladder. In the gallbladder, it will tend to accumulate, and as a result, it will form the gallbladder stones, and in the serum its level will be highly raised. After that, we have the urobilinogen presence in the urine in the case of the hemolytic anemia, which actually impart the dark color to the urine, all right, on the exposure of light. Then we have the serum haptoglobin. I have told you about the haptoglobin, that it is a serum plasma, it is a plasma protein, and it has the ability to bind the hemoglobin with it. As it will bind the excessive amount of the hemoglobin with it, its amount will be reduced definitely in the serum, all right, or it may become absent even. Then we have the reticulocytosis. Reticulocytosis is also a result of red blood cell destruction. As there is the red blood cell destruction there will be increased signal to the bone marrow to increase the production of the red blood cell. As a result of this, the immature red blood cells, retics, will get the access, and they enter into the blood, and we will see the reticulocytosis, the increased number of the reticulocytes in our blood. And then we have the bone marrow erythroid hyperplasia. It is something which is exactly due to the red blood cell destruction. When there is red blood cell destruction, there is more signal to the bone marrow to increase the production of the red blood cell. As a result, the erythroid production will be increased. There will be hyperplasia of erythroid, and we will get the ratio disturbed of myeloid and erythroid. The myeloid and erythroid ratio in a bone marrow is normally 2:1 to 12:1. It will become 1:1 or reverse in the case of the hemolytic anemia cases. एक्चुअली क्या होता है कि हमारे पास अगर हमारे पास हीमोलाइटिक एनीमिया है, मतलब कि हमारे पर रेड ब्लड सेल की डिस्ट्रक्शन ज़्यादा हो रही है। अगर रेड ब्लड सेल की डिस्ट्रक्शन ज़्यादा हो रही है, बोन मैरो को इंक्रीज सिग्नल जाएगा, ज़्यादा सिग्नल जाएगा कि आप रेड ब्लड सेल की प्रोडक्शन को इंक्रीज़ कर दो, ठीक है, क्योंकि जब रेड ब्लड सेल की डिस्ट्रक्शन होगी उसके नंबर डिक्रीज़ हो जाएंगे, ऑलराइट। तो हमारा बोन मैरो ज़्यादा कोशिश करेगा कि उसको नॉर्मल रेशो पे, नॉर्मल अमाउंट पे रखे, नॉर्मल रेंज पे रखे, ठीक है। तो इसकी प्रोडक्शन रेड ब्लड सेल की ज़्यादा हो जाएगी। फिर हमें क्या मिलेगा? एराथ्रॉइड हाइपरप्लेजिया मिलेगा। एराथ्रॉइड्स की जो प्रोडक्शन है वो ज़्यादा हो जाएगी, हाइपरप्लेजिया हो जाएगा उनका, जिसकी वजह से जो हमारे पास मिलाइड एराथ्रॉइड रेशो है, जो नॉर्मली 2:1 से 12:1 होती है, वो हमारे पास 1:1 या इससे रिवर्स हो जाएगी, ये डिस्टर्ब हो जाएगी। एंड द पेरिपेरियम विल आल्सो शो द फ्रेगमेंट्स of these fragments will be of rubber cell. Elliptocytes means that the rubber cell will show the elliptical shape, and the microspherocytes. तो ये पॉइंट आपको क्लियर हो गया होगा कि माइक्रोस्फीरोसाइट जो है हमारे पास जब भी हेमोलाइसिस होती है तो ये हमारे पेरिपेरियम के अंदर इंक्रीज अमाउंट में आते हैं, ऑलराइट। तो इनकी प्रेजेंस हमें ये बताती है कि देयर इज हेमोलाइसिस इन द बॉडी, okay. Then this is all for today. Hope so you have learned a lot, and if you have any question you can drop it in the comment section. Thank you for your attention.